Hello everyone, welcome to our coverage of Chapter 13, Pregnancy and Childbirth. This will be part 1. I've gone outside of your chapter quite a bit to provide you with some updated statistics and cover some issues that many of you have been raising in your perusal questions and in your discussion threads. Much of the information that I'll be presenting today, as will be indicated on various slides, comes from the National Center for Health Statistics, the CDC, the Centers for Disease Control, and the Department of Health and Human Services website that's particularly focused on women's reproductive health and other health issues related to women, womenshealth.gov, which is an excellent educational site. First, just some basic statistics about how many babies we're having as a culture. And this is data coming from the National Center for Health Statistics. The latest updated report is from 2018. The number of births, well over 3 million, pushing toward 4. The birth rate at the moment is 11.6 per 1,000 in the population. The fertility rate, 59.1 per births per 1,000 people, or 1,000 women who are of reproductive age. The percentage of babies that are born with low birth weight is about 8.3%. The percent preterm is 10%. The percent of births to people who are not married is 39.6%, and that unmarried status is connected to the number of women giving birth who are unmarried. The average age, if you include both mothers and fathers at first birth, is 26.9, which is considerably higher than in previous generations, particularly for women. Now, some other birth statistics from the CDC. There is a gender difference, a sex difference for mean age at first birth. For women, it's a bit lower than it is for men, at 23.6. For men, it is that higher number of 26.5. The percentage of women of reproductive age who had a biological child before they were 20, and I found this statistic a little bit surprising, was 27.3. So you still have a significant percentage of women who are having their first child or having a biological child before they're 20, but the vast majority do not. So that means that they're after 20 having their biological children. The percentage of men who've had fathered a biological child before the age of 20 is much lower than what we see for women of reproductive age. That's 10.7% who have fathered a child before 20. If we're looking at the statistics for number of children between the years of 2015 and 2017, the percentage of women of reproductive age, so between 15 and 49, who have no children, is just under 42%. And for women 40 to 49, so that would be largely women who are beyond their reproductive years, is about 15%. The percentage of women of reproductive age who have report having one child is just below 17%, which is about roughly the same as for women from 40 to 49. Those who have 2 children, the percentage is higher, 34 for women 40 to 49 than it is for those with 2 children. And then, you can see the remainder of the statistics there. So what this shows is that for younger women who are of reproductive age, we're seeing the percentage of those women who are not having children, who have no children, has been going up in recent years. Part of that is because women are delaying having children in the first place, so they're having their first children later than they did in previous generations, and many are pushing that buffer to 40. So we're seeing an increase in births into between that range of 35 to 40 more frequently than we have in past generations. Now, for the number of biological children ever fathered, and this kind of reflects the difference in reproductive potential and the fact that for men, there really isn't this 15 to 49 buffer zone of fertile potential. Men, as long as their reproductive system is intact, can continue to produce sperm throughout their mature lifespan. So we don't see quite as much of the same pattern that we would see with women. For men between 15 and 49, over half of them surveyed in that period 2015 to 2017 had no children, whereas for men between 40 and 49, about 23% did. So what you're seeing there in comparison to women, you're seeing a larger percentage of men during that 15 to 49 years of age period reporting not having children, which is a difference in when you're comparing men and women. Now the marital cohabiting status of mothers and fathers at the time of birth, these statistics reflect some cultural changes that we've been experiencing over the last couple of generations. For mothers at the time of birth, about 54% reported being married or formerly married. About 24% report being cohabiting, and about 23% report being unmarried. So you have about, in that 20 to 23% range of individuals who are not married and they're not cohabiting, nor have they been married. And that's a number that has fluctuated. It has been increasing in recent years to some extent, although that's very, very dependent on social status, things like socioeconomic status, and to some extent there are some correlations with race and ethnicity. For fathers, the percentage that were married or formerly married is 60%, cohabiting 26%, and unmarried and not cohabiting was 13.8%. So you see somewhat of the same pattern in fathers and mothers in terms of their marriage cohabiting status at the time of the birth of their children. Now, pregnancy intention is a construct that is used in both public health as well as in sociology research to talk about what people intended at the time they found out that they were pregnant, or what their intentions are more broadly. There tend to be some categories that are used in the literature. You have pregnancies that were intended, where people intentionally were not using birth control and they wanted to get pregnant. There are pregnancies that were not intended and the pregnancy is not wanted, so it's an unwelcome event. You have mistimed pregnancies where you were neither trying nor not trying, but you have had a pregnancy regardless. And then there are pregnancies where the parties, whether you're talking about mothers or fathers, are ambivalent in their emotions about whether they feel good about the pregnancy, and in fact, the parties may be unclear as to what their intentions were, or the people involved in the pregnancy may have mixed motives or mixed understandings of the nature of that pregnancy. Regardless, when people experience unintended pregnancies, whether they're wanted, mistimed, or whether they're ambivalent about them, the research has shown some correlations with negative outcomes. Some of those are negative outcomes for the parents involved, particularly for mothers, and some of the negative outcomes are for the babies that are born, or for, in fact, the pregnancy and the quality of that pregnancy. Now, as your textbook stated, A lot, a significant proportion of pregnancies were unintended. And the statistic that's often reported is hovering around 50% of pregnancies being unintended. Um, and then you look at that unintended number, and you break that out further. Um, just below 30% were reported as being mistimed. And mistimed means, you weren't necessarily planning to get pregnant right now, but you are. So it could be, a cohabiting couple or a married couple or a couple in a long-term relationship who were using contraception, but their contraception failed. That's a mistimed pregnancy. Or maybe it's a woman who was a bit later in her reproductive life, say, well over or 30, pushing 40, and didn't really think it was all that likely that she might become pregnant, but she becomes pregnant. That's an example of a mistimed pregnancy. And then you have just under 20% of people in this particular survey reported that their unintended pregnancies were unwanted. Now, those numbers that you're breaking apart there in this particular study, they aren't really clarifying the distinction between intended and unintended, mistimed and unwanted. It would be helpful if the statistics here included how many reported that the pregnancies were intended in addition, but that data isn't present here. All right, so for the remainder of the presentation, what I thought I would do, because your chapter gives you kind of the facts, the basic facts. How I'm going to talk about the next few slides is as if you're projecting out into the future, you're pregnant or your partner's pregnant, what happens next? I think far too often, until people are faced with the actual fact of pregnancy, they don't take the time to really think through what the process might be like. They may have experience. I mean, some of you may have siblings who've had babies. Some of you may have significantly younger siblings, so you've been through that experience within your own family. Others of you may have, no experience other than just media exposure. So first, you need to think about who are the healthcare professionals who are going to help you to monitor your pregnancy, to help you be healthy during your pregnancy, and to educate you during that entire process. There are a number of healthcare professionals who specialize in the care of pregnant women. Obstetricians and gynecologists are an obvious specialty that comes to mind. So these are MDs or DOs who have a specialization in pregnancy and women's health, women's reproductive health, and in delivering babies. OBs, obstetricians, have special training in surgery so that they can do cesarean sections and other kinds of surgical procedures if necessary. Now, obstetrician and gynecologists, obstetricians really specialize in childbirth and pregnancy. Gynecologist practices are more broad and focus on reproductive health generally. So if you're thinking, what kind of professional do I need? Women who have pre-existing health problems or have risks of pregnancy complications, the recommendation by the Surgeon General, also by the national organizations that OBs and GYNs belong to, recommend that those are women who should be in the care of an OB/GYN. Women with the highest risk pregnancies, and there are a wide variety of categories of women that might fall into that range. They may require additional special care, and in that case, there are physicians who specialize in maternal fetal medicine. So, for example, if you have a woman who has the potential for having placenta previa and that has had a previous pregnancy loss. As a result of that condition, a fetal medicine specialist may be recommended to monitor much more carefully, much more closely that pregnancy. There are also family practice doctors who provide labor and delivery services. It's not as common as it used to be. Family practice doctors used to be the attending physician at births quite regularly, but in recent decades, the expense of insurance coverage for family practice doctors to do labor and delivery has become cost prohibitive. So it's become relatively rare for family practice doctors to also do labor and delivery. Part of the challenge for family practice doctors is that most of them do not have a surgical specialty, so they're not going to be able to do cesarean deliveries. And that would necessitate bringing in other specialists, other professionals in order to do those kinds of surgical procedures. Other professionals are a whole, there's a whole spectrum of individuals here who provide services to women who are pregnant and during their deliveries, and also provide supportive care and education postpartum. You have certified nurse midwives. So these are individuals with nursing training who also specialize in midwifery, which is helping women with their pregnancies and delivery and postpartum care. They're also certified professional midwives who do not have nursing training per se, but they are specially certified in the states where they reside to provide pregnancy and postpartum care. Finally, there's a profession called a doula, and these are individuals who are not going to necessarily be providing medical advice or doing a lot of the monitoring and things like that during pregnancy, but they are there specifically to help teach women and their partners how to manage labor and delivery, and then they serve as a labor coach. So their work is to provide physical and emotional support to women during labor and delivery. Now, there are states which have special certifications for doulas, and other states which do not. Most states are moving in the direction of greater supervision, but there are national organizations for both midwives and for doulas. You also need to think about where you want to give birth. Hospitals in the United States, since probably the 1950s, most births started to be conducted in hospital settings. Prior to that, my parents' generation, many babies were born at home, and that was pretty normal. But during that time period, as we passed the 1940s and into the 1950s, especially kind of climbing rapidly in the 1960s and 70s, we saw more and more babies being born in hospitals, and frequently under general anesthesia in those early years. So my mother, for example, all three of her children were delivered under general anesthesia. Now, that has changed. That is not the normal standard today by any stretch. But hospitals, you're encouraged in your generation to look at what your options are. So you have a full range of choices, from hospitals to birthing centers to giving birth in your own home. Hospitals are recommended for women if they have pre-existing health problems, if there are complications in their pregnancies, or if there are risks that they know that they have a potential of facing during labor and delivery. And the reason why, you have ready access to surgical teams, to all of the technologies that can help you to have a successful outcome without the delay of having to be transported from either a birthing center or from your home to a hospital. Birthing centers are relatively speaking, newer kind of phenomenon in the United States. These are special, either standalone or within a hospital centers, which are designed to create a more comfortable, warm, less kind of technologically heavy environment for surrounding women and their partners or families as they give birth. They often have staff which are a mixture of medical and non-medical. So for example, you have frequently at birth or birthing centers, you have nurse midwives, doulas, as well as ready access to other kinds of medical professionals. Some, as I said before, some birthing centers are freestanding. They may be attached to women's health facilities, or they may stand on their own. Other birthing centers are built within a hospital kind of complex. Regardless, these are places where they kind of represent a mid-range, where you can have a more comfortable, less medically intense environment, but not be at home, where you don't have quick access to more intensive medical care should the need arise. Home birth is an option. If you talk to medical professionals, the tendency is for medical professionals to kind of look at you and say it's a seriously bad idea, whereas other individuals will come back and say, look, women have been giving birth at home for generations upon generations, and in lots of parts of the world they still do. You always need, as you make decisions for yourself and for your family, you need to take some of the facts into your decision-making process. Home birth is not without its risks. In countries where there is not access to complex medical care, where women don't have access to professionals to help them with childbirth and delivery, it is clear that maternal mortality is higher. So, and even within our own country, in places where women don't have adequate access to hospital care for labor and delivery, we do see increases in high-risk deliveries, in birth injuries, and in maternal deaths. So home birth is really only recommended for women who are currently healthy and who don't have risk factors for complications. Now that doesn't mean that a problem wouldn't arise. It could. It is also recommended that if you're going to plan a home birth, that you work with a certified nurse midwife who has a relationship with appropriate organizations, including hospitals, and who would, be in agreement that you would be transported should problems arise in the pregnancy. There are some doctors, although this is a relative rarity, there are still some doctors who deliver babies at home. I don't have good data on where that occurs more often. If I find it, I will pass it on to you. Now, as a pregnancy progresses, some other things that you really need to think about is how to take care of yourself before you conceive. Now, obviously, with 50% of pregnancies being unintended, this is, once you're pregnant, preconception care is kind of out of the window. But if you are, planning to get pregnant, you're hoping to get pregnant, it's helpful and it's healthy to do some preconception things. Some of it is just fine-tuning your lifestyle. Some of it could be quite significant changes to your lifestyle and to your health prior to conceiving. So for both women and men, it's important, and you shouldn't, if you are men and you're listening to this, you shouldn't downgrade the importance of your physical and mental health before conception. There are many health-related behaviors that can influence the quality of sperm, and the motility of sperm for conceiving. So this isn't just information for women, but also for men. The recommendation is that about, at least 3 months before you want to try and get pregnant, that you take a hard look at your lifestyle and some of your health-related behaviors. For women, it's important that you get enough of what's called folic acid every day, because there's a definite connection between inadequate amounts of folic acid and specific forms of birth defects, including spina bifida and other neural tube defects, including cleft palates, for example. So physicians recommend, even before, during that preconception period, if you are intending to get pregnant, what many doctors recommend is you just start taking a prenatal vitamin, because it's going to include both the iron and the folic acid that you will need to support a healthy pregnancy. And there's some evidence that shows that in that preconception period, making sure that you have adequate folic acid further reduces the risk of some of those birth defects, if you have that level up and on board before your pregnancy. For both men and women, it's recommended that you stop smoking. Smoking has definite negative impacts on growing and developing fetuses. There are a wide range of them. I'm not going to review them here. It's also important that partners, anyone else living in the home of someone who's planning to get pregnant or who is pregnant, that they also either stop or greatly reduce their smoking in the presence of a pregnant human. Drinking alcohol, using illegal drugs. For women, when your fertility can be affected by heavy uses of alcohol, it can also be affected by the use of a range of illegal drugs. In addition to affecting fertility, it can interfere with decision making and all kinds of other risks that you might take, such as driving while intoxicated and impaired. For men, if you have a pregnant partner or a partner who's planning to get pregnant, thinking about your alcohol and drug use is an important step to take. Again, use of alcohol and illegal drugs can increase risky behaviors across the board. At least it's been correlated with those. Now, there's varying research on alcohol. Clearly, what we know is that regular, even moderate use of alcohol can be very problematic for pregnancy and can have very devastating effects for the growth and development of the baby. Where there's less agreement is what is the impact of small amounts of alcohol periodically, especially if it's only consumed late in pregnancy. In some cultures, and there are tremendous cultural differences here, if you just cross the border into Canada, the advice is somewhat different on alcohol consumption. In the United States, physicians typically recommend zero consumption of alcohol. In some cultures, in Canada, in parts of Europe, the restriction is not quite so severe. But if you speak to a doctor, let's say you're intending to conceive, you will likely get the message: zero alcohol, zero smoking, absolutely zero illegal drugs. If you're planning to conceive and you have a pre-existing medical condition, let's say you have diabetes or rheumatoid arthritis or something like that, you need to make sure that you have conversations with your healthcare professionals who manage those conditions, and that you talk to your OB/GYN about what the impact might be of those conditions. Now, for some families, they may have risk factors for genetic disorders. For example, I have a former student who, her husband carries the gene for cystic fibrosis. So before they tried to conceive, she needed to be tested to see if she also carried the gene. So there may be specific kinds of medical conditions that you really need to think about before you conceive. You should also make sure that you are very candid with your doctor about the over-the-counter kinds of drugs and supplements that you take. You know, Americans, we love our over-the-counter drugs and we love our dietary and herbal supplements. You need to talk to your doctor. And what you're likely going to hear is, if there isn't concrete evidence that there won't be any harm, you will be told to stop taking it. So there are some medications that we know have negative effects, and your doctor will probably give you a list of those if you're trying to conceive or you are pregnant. For supplements, for dietary over-the-counter things, like the stuff that you could go and get at your local health food store or even on the shelves of Giant Eagle, you need to do your research. And there are numerous sources out there, especially your pharmacist and your physician. You also need to make sure that your vaccinations are up to date. There are certain kinds of diseases like chickenpox and measles that can be very problematic for pregnancy, causing miscarriage, causing severe birth defects, and so on. So at that preconception time, you will be asked to, if you have a new healthcare provider, you'll be asked about your vaccination history, and if you don't know, you'll probably be revaccinated for some of those conditions so that your baby will be protected. You will also be encouraged, if at all possible, to avoid contact with certain kinds of toxic substances that could either cause you to contract an infection or certain chemicals that we know are dangerous to a developing fetus. One recommendation, we know that there are organisms that tend to find their home in cat boxes. So if you have a cat at home, you will get a 9-month break from cleaning the cat box because you will not be the one touching it. Toxoplasmosis is very problematic for pregnancy, and cats are known carriers, as are certain rodents, carriers of other kinds of infectious agents that can be dangerous for pregnant women. Now, sex actually does happen during pregnancy. I know from teaching this class over the years that sometimes students are like, what? You have sex during pregnancy? Can't that be a problem? No, not usually. Now, some people report, and this is for men and women, for partners, sometimes they report that they're less interested in sex during pregnancy, while others report that their interest in sex actually goes up. And the rates are roughly equivalent for men and women. So there's a stereotype that women, when they're pregnant, have absolutely no interest in sex, and that is a stereotype. It is not borne out by the data. And the stereotype about men is that they'll want to have sex, but not with you. And again, that stereotype is not supported by the evidence. In the third trimester, there does tend to be a decrease in the frequency of sexual intercourse, and part of that is a mixture of physical discomfort for women during that stage of pregnancy, but also the concerns that both women and men have that having intercourse, having sex, may harm the baby or may somehow trigger preterm labor. Generally, couples report that their level of sexual satisfaction, so their level of satisfaction with the sex they are having, remains high, often reporting that this is a time where they feel particularly close to one another, particularly excited by each other, and so on. The most common reason that people report for not wanting to have intercourse during pregnancy is that they're worried that they will harm the baby. And what their OBGYNs will tell them is, the baby's fine. The baby's safe in its own little space, and there's nothing that impinging penis can do to hurt it. Generally speaking, having penile-vaginal intercourse is not going to cause a risk to a developing fetus or to the mother's health. There are some special circumstances where that is not the case, and there will be specific recommendations to avoid penile-vaginal intercourse under those circumstances. Sometimes if you have physical discomfort while having sex during pregnancies, you can try alternative positions and different kinds of techniques to increase your level of comfort, particularly in the later stages of pregnancy, because your body is not just your own during that period of time. You may have to work on your technique just a bit. Now, I mentioned before that there are some conditions that make penile-vaginal intercourse risky. If you have, during your pregnancy, already some vaginal bleeding or the existence of abdominal pain, it would be recommended that you not have sex. If there has been a rupture to the amniotic sac, if you have been checked by your doctor and you have dilation, but it's in the second trimester, it may be recommended that you not have sex. If you have a history of premature delivery or a history of miscarriage. And all of those things are something that you have to have a conversation with your healthcare provider about to understand fully what the ramifications of those various conditions might be. All right, so for prenatal care, in the United States, for people who have adequate access to medical care, so that's a huge caveat because there is a significant percentage of women in the United States who do not have adequate access to anything I'm going to describe right now. So we're talking about people who have doctors, people who go to OBGYNs, who have a relationship with those healthcare providers. This is what you would typically encounter. So if you have that access to prenatal care, there will typically be routine checkups throughout pregnancy, once a month through 28 weeks, twice a month for 28 to 36 weeks, and then weekly from 36 weeks until birth occurs. Women with high-risk pregnancies, and that can include, factors such as health conditions or just advanced age. I remember being a bit miffed when I was declared not high risk, but moderate risk, but because I had, quote, advanced maternal age, I think I was 34. I found that mildly offensive, but anyway, high risk pregnancies will likely have to see their doctors more often to monitor their whatever conditions have placed them in that category. The first time you see your doctor, you will likely have a full physical. You'll be giving some blood for lab tests, and there will be a calculation based on, at the very least, your last menstrual cycle. Now, some people who are very carefully intending to get pregnant will have an exact, within days, estimate of when they conceived. Other people, remember, about 50% of pregnancies are unintended. They may be a little more fuzzy about that. So depending on how much you know about your body and how carefully you've tracked your menstrual cycles and your sexual activity, you will either be less certain or more certain as to when you conceived. Also during this visit, you will be asked a lot of questions, and it's very important that you be honest. Your doctor will ask you about smoking, your diet, your alcohol consumption, your drug consumption, the nature of your relationships, including whether or not there's violence in your relationships, and also more broadly your health habits, your eating habits, your exercise habits, and so on. Now, in some ways this can feel intrusive, but in other ways what your doctor is trying to do is to get a sense of what are the things that you can do right now to maximize the possibility of having a healthy pregnancy, a healthy delivery, and a healthy baby. After the first visit, the prenatal visit, the checkups will include weight and blood pressure. After the baby's heartbeat can be checked on Doppler. They'll check the heart rate. They'll take measurements of your abdomen to chart growth of the baby. Routine tests are also done, blood and urine tests throughout the duration of the pregnancy at very specific times to make sure that you don't have anemia. There will be tests for gestational diabetes because that can be a dangerous condition. Some pregnant women develop diabetes-like symptoms of blood sugar dysregulation during their pregnancy just as a result of being pregnant. So that needs to be monitored and then addressed if diabetes occurs. There will also be some tests to make sure you don't have some harmful infections that could cause birth defects or could cause preterm delivery or even miscarriage along the way. Again, this kind of prenatal care is available to women who have good access and can afford this kind of prenatal care. So you need to think about the fact that if you are poor, or if you are poor and you have a reason historically, sociologically, to distrust the medical establishment, or let's say that you are undocumented, your access to this kind of care, this level of care, is limited at best. So a good percentage of women, even in an advanced culture like ours, do not get good prenatal care. As a result, we see in America higher levels of both maternal mortality and infant mortality than in other comparable industrialized cultures, because we do not have the kind of access for particularly poor people and people of color, and for people who are undocumented, in order to make sure that they get good prenatal care and checkups during pregnancy. Some prenatal tests that you should expect to have at your first prenatal test. You'll be asked to give some information about your blood type. So you're familiar with, there are people who, like, my blood type is A negative, so is my husband's. If you have a situation where you have a negative and your spouse has a positive, you'll need to take some steps with the Rh factor. So you'll need to have some tests to check for the Rh factor. If you don't know your blood type, you don't know your Rh factor, you need to find that out. If the baby's Rh factor is incompatible with the mother's Rh factor, it can cause problems during birth. You'll be tested at your first visit for anemia, so that can be addressed. You'll likely be tested for STIs and for toxoplasmosis, as well as for hepatitis and HIV, because all of those can have impacts both on pregnancy, but also for STIs in particular. Things like hepatitis and HIV need to be addressed, because you're not going to make those go away during pregnancy, but you can ensure that the baby, or you can not 100% ensure, but you can greatly reduce the likelihood of those being transmitted to the baby during birth. You will also be tested to make sure that your immunity is present for both rubella, German measles, and chickenpox. So even though, for instance, I had my vaccination records and I was up to date on my rubella vaccine, I was tested, and I had chickenpox as a kid. I was still tested to make sure that my immunity was intact. And part of that has to do with the fact that there's increasing evidence that some of our childhood vaccines, for some people, do not maintain immunity as long as for other people. And there was a period of time I had to be revaccinated for measles, mumps, and rubella when I was in graduate school, because it was determined that people in my generation, that the vaccines were less effective long term. So we all had to be revaccinated during that period of time. There may be other tests that are recommended. Some tests are suggested for all women. There are some tests that are done. They're based on blood tests and norms, and they're also connected to your estimated delivery date or due date. In addition to gestational diabetes, you'll also be given what's called a triple test, which is designed to, based on normed data about other births, to look for some markers in those blood tests that might suggest that you're carrying a baby that has a genetic anomaly or some other kind of condition. And it's important that the due date calculation be fairly accurate to interpret those results. If the due date estimate is off, then the likelihood of being able to accurately interpret the test results would be off as well. What would happen, let's say, for example, and this happened to my husband and I, we got results on the triple test that suggested that there was a possibility that the baby we were carrying had a genetic anomaly, and a fairly severe one. So that's only step one. The next step is you meet with a genetic counselor who goes through an extensive family history and asks a lot of questions. And then you would go for what's was described to us as a high-risk ultrasound. And what they do is spend a very long time taking lots of pictures, lots of measurements of that developing fetus. And in this case, this was second trimester. So they wanted to get some pictures and see if what was shown on the triple test as a possibility was actually evident in the fetus on screen. Luckily for us, they had my due date written down wrong in my chart, so everything was good. Other tests might be based on your age. The older women get, especially as they cross that barrier from 35 to 40, age can present some additional risks. And we are learning that for men, there is some evidence that for some genetic conditions or conditions that are contributed to by genetics, that advanced paternal age can also present a risk, although that research is less clear. There are certain personal and family health history variables to take into consideration. I mentioned earlier cystic fibrosis risk, but there are other kinds of conditions that are heritable that you need to consider. Same goes for ethnic background. There are some ethnic groups for whom certain kinds of medical conditions need to be considered as something that may complicate a pregnancy or be something that your fetus is likely to develop. And that's kind of a thumbnail sketch of the prenatal test that you would likely be looking at coming at you. I know that I wish I had taken the time to review everything that I've just talked to you about before, and our pregnancies were very planned, plotted, but I wish I had taken the time to prepare myself much better for the kinds of things that I would experience during that prenatal period. If I had done so, I wouldn't have been surprised by things like a triple test result that suggested something horrible, or I wouldn't have been so irritated with my doctor constantly wanting me to pee in a cup, that kind of thing. So it's helpful to be aware of all of the prenatal testing and prenatal visits that you're likely to encounter. So that concludes part 1 of our journey through Chapter 13, Pregnancy and Childbirth.